So obviously I'm biased, but bariatric surgery does continue to be the treatment option that has the most significant and sustained weight loss for both children and adults. And it's actually the most cost effective if you're just looking at the economic side. And that's because although about 20% of people who get, 20% of adults who get bariatric surgery regain their weight, about 80% of people who stop their GLP-1 medications regain their weight. So in the long term, surgery still outcompetes medications from a cost effectiveness standpoint by a long shot. And there are actually more and more data in kids showing how useful the early intervention can be. And there are even benefits in children if they regain some of their weight after bariatric surgery. Some recent publications have shown 10 and 15-year follow-up data that include health benefits for children who underwent bariatric surgery as teenagers. And that's like it's amazing to think of that you can do an intervention as a 15-year-old and still having a benefit for the patient when they're 30. So really, again, no reason to withhold the different treatment options from children. And I can tell you in my own personal experience, having done more pediatric bariatric surgery than anyone in the United States, it is very safe and it is very effective and can be done in almost any different patient population. My particular interests, including gene monogenic obesity and children with special healthcare needs, I've shown in those populations and in people younger than 12 or 12 and younger that it can all be done safely and effectively. And so I go above and beyond what the American Academy of Pediatrics recommendations might be, but I can assure you that I've published all these data and they're all real. And there's, again, no reason why an 8 or a 10-year-old can't get bariatric surgery if they need it. So I, again, recommend early referral if you have access to places that can provide that intervention. But the numbers are still unbelievably in favor of showing that surgery is underutilized. So only about 1% of eligible adults get bariatric surgery, and about 0.2 to 0.1% of eligible children get it, which, again, if you're looking at a cost effectiveness strategy, is a huge waste. Sorry. And what makes the surgery different today than it was when it first became popularized in the late 1990s is that we don't do it through an open incision anymore. Everything's done laparoscopically. So it means that the complication rates are really low, under 1%, and the hospital stays are usually a day or two. And the procedure that is most often employed has shifted from the gastric bypass, which reroutes the intestines, to something called the sleeve gastrectomy, which really just makes the stomach much smaller. And I personally think that with the advent of the GLP-1 medications, I think the strategy moving forward for many is going to be the laparoscopic sleeve gastrectomy because it's so safe and effective, almost as effective as the gastric bypass. And then if you have weight regain or don't lose enough weight with the sleeve gastrectomy, you'll get medication as well. So combination therapy, almost like chemotherapy and surgical resection for cancer. So for obesity, it's going to be surgery and medication, not just one or the other. And I think that's where the field is evolving to. And I think that's true whether it's in kids, where right now it's recommended down to age 13, although I talked about my experience with children under 13 and with the other neurological differences. So I think that's where the whole field is moving in general. Both pediatric adult and adult obesity management is going to be surgery and medications. And whether it's medication, surgery, medication, or surgery first and then medications, or medications and surgery, I think that's where the clinical studies need to be done so that we can sort of optimize the use of these different modalities in conjunction with each other, not continuing to assess them individually.